I do research in sickle cell, I do consulting. I'm going to discuss publicly available information, a little bit of things that are off-label because of the application to acute blood problems, but almost all of it is going to be just general terms with no endorsement of commercial products. And the objectives are here. That sickle cell is an inherited anemia that affects people all over the world, that we try to identify the idea that specialist care is needed for optimal management of this multi-system disorder, and then summarizing how there are actually now new non-transfusion preventive options, to reduce the risks of having acute problems in sickle cell disease. So the idea is to plug in individuals with sickle cell care with preventive type of issues so they don't need to have those acute emergency type of rescue problems. So let's get going. Any talk about sickle cell disease from a hematologist is going to include a slide like this showing what the red blood cells look like under the microscope. And the reason for the name sickle cell is that the cells are shaped, instead of like a normal biconcave disc shown here, sort of looking like little donuts, that you have some with the elongated shapes that are curved or pointed at both ends. And so under the microscope, it has this general appearance. And this has been the main idea of sickle cell disease for textbooks and all kinds of different pathophysiologic understanding for a long time. And so we now call this the, quote, classical understanding. If you want to look at this in a more high-tech way, you'll start to see with animations like on this website, rethinkscd.com, which I'm not going to show right now, so I don't crash my computer. Animations like this will show you how the pathophysiologic understanding of sickle cell is actually starting to advance in the last decade or two. Besides seeing the blood vessel with blockages of the curved and rigid cells, making a logjam type effect like here or like here, you also have white blood cells involved, these large bluish blobs, blue-white, almost like icy things. You also have platelets involved, these little yellow things, and that stickiness between the cell-cell interaction within the blood cells, cell-cell interaction between the blood cells and the endothelial lining of the blood vessel are all abnormal and showing those are part of the pathophysiology of sickle cell. This will be important as we get to why we have new therapies. And then you have the blood vessel lining itself is starting to look abnormal. So it's not completely clear here, but you'll see that the blood vessel lining gets this heaped up area. You see this little hill of endothelium, where usually it should be just smooth or single layers. Now you're getting multiple layers and it's starting to impinge upon the blood vessel lumen. This is part of the vasculopathy of sickle cell. So if you want to go review this high-tech visualization, you can do that. But I'm going to show you also in a low-tech way. One of my other occupations is sometimes I'm a Sunday school teacher, and so I do a lot of things with visual aids. And so here's an imaginary red blood cell, if you can see in my hand. So this is biconcave, it's squishy, it's kind of flexible, it can move through different blood vessels. And in contrast, the sickle cell might look something more like this, curved, pointy at both ends, kind of hard, and kind of breaking up at the ends too, because of the polymer inside, this rigid rods. Another way to look at this might be that it's like dried chili pepper. So dried red chili pepper can look something like this, and it gets to be dried and flat and maybe start to break. And then you have release of the contents. And if you have a chili pepper, you release the contents, it gets kind of exciting, gets to be inflammatory. And that's what release of the hemoglobin from inside the red blood cell can do too, is the release of hemoglobin causes inflammation in the body, oxidant stress. Some of the pathophysiology of sickle cell is this hemolysis, this breaking of red blood cells, just like a chili pepper would do something like that. But what does this mean for your blood vessels? Well, let's imagine that this is a blood vessel, and the job of this blood vessel is to deliver the red blood cell from one end to the other so that oxygen transport can occur. And let's pretend that this apple, which will be my breakfast later, is a red blood cell. And we're going to try to get this through the blood vessel. And a normal red cell can do that pretty well. So you have flow, whoops, and it goes on through. But if you have a sickle red blood cell, shaped maybe more like a banana, it has trouble getting through, partly because of its shape. And so you have something that's going to try to go through. Do you think it can make it? It gets stuck, and it gets quite stuck. And even if I try to squeeze it through, it's going to have a hard time. If I, however, do some vasodilation, if I open up this blood vessel, and I'm right-handed, so I'll do it from this other side. If I can open up this blood vessel so it's not so constricted, and so vasodilation can occur with relaxation exercises, with prayer, with maybe heat or medications. And so those can help you to open this blood vessel and get this rigid thing that doesn't go very well through. And so you can finally deliver that to the other end. The other problem, we talked about cell-cell adhesion. So you might have a blood cell that's sticky, got something like adhesive tape on it. And so we'll put some adhesive tape onto this apple and see if it can still make it through the blood vessel. And when you put some adhesive molecules, abnormal adhesive molecules on a sickle cell, it'll tend to get stuck. And so that is part of the new understanding of pathophysiology of why blood cells can get stuck during times of infection, that the infection activates some of these abnormal adhesion molecules. And so now you have a blood cell with many little things sticking out. And so trying to get that one through this blood vessel is more of a chore even than before. Through this narrow blood vessel, the stickiness really causes you problems, and I can get it through, but it takes more effort because of this cell-cell adhesion. And so again, hemolysis, breaking up of blood vessels, could occur inside there, could occur elsewhere in the body, and these free hemoglobin molecules are causing distress, oxidant damage, nitric oxide consumption, causing vasoconstriction like this, whereas you can counter that with vasodilators, making the blood vessel more relaxed. Or you can also hydrate the person well, so you open up this blood vessel, really let the blood flow. So that's the low-tech understanding. And again, that animation on that website shows it in a high-tech way. Just a reminder now that sickle cell disease is a global problem, that I'm here in the United States on this world map. There is some incidence of sickle cell in the United States, as well as South America. Brazil has a lot, Central America, Caribbean. But in sub-Saharan Africa is where a great deal of people have sickle cell disease. So that and then over in India, Pakistan, through the Middle East. And so this is really a global problem. I've recently given a talk in Australia, met with sickle cell groups in England, in Lebanon, in Brazil. So that many people across the world are affected. And this is because the sickle gene and people with sickle cell disease, sickle trait, have moved voluntarily or through slavery or through war or through economics. And you have sickle genes all over the place. So this is becoming a global issue. The hallmark of sickle cell disease is severe acute pain. This is a painting from a gentleman with sickle cell disease who was an artist and was showing that if you ask me, what is my pain level? And I say 10 out of 10, you don't maybe know what I'm talking about, but this is the painting to show how bad that pain is, that this is tears streaming out of my eyes, screaming, nothing, I can't think of anything else except for the sickle cells, which are some of these blue curved objects here that maybe aren't projecting well on the screen. And then there's the red blood cells that are kind of these biconcave things. So he titled this painting 10, meaning if you have a pain score, this is 10 on a scale of 10. The artist Hertz Nazaire was from the Caribbean and moved to the United States. And he recently, just this week actually, just passed away from complications of sickle cell disease. And so we honor him and we think of him and how well he was able to express things. When we think about sickle cell, besides the pain, however, there are many other medical issues that arise because if you think about it, this blood flow problem, the blood vessels, the blood cells, the hemolysis, those are occurring through the whole body. And so different parts of the body, pretty much every organ system you can think of is affected. So you can have lung and heart problems shown here. You can have bone problems. You can have CNS problems, the brain, the spinal cord. There's strokes, there's infarcts, both that are hemorrhagic, it's ischemic ones. I've had children who are as young as 2 years old who've had stroke. And then the eyes can have problems, retina problems shown here, proliferative retinopathy. The spleen can be damaged very early in life so that the functional hyposplenism is part of the problem of sickle cell. And we will talk a little bit more about that later. Avascular necrosis shown here for the skeletal system classically hits the femur and the humerus, but that can also hit other places too. And I've recently learned that avascular necrosis concept can affect the teeth. The tooth pulp can actually get avascular pulp necrosis. And there can be a dental problem without an infection, just due to sickle cell in the middle of the tooth. The genitourinary system heavily affected by sickle cell. So kidney damage, there's like 7 different kinds of kidney problems that can occur in sickle cell, starting from a very young age, renal tubular concentrating problems, moving on to glomerulopathies, glomerular leak of protein, sometimes bleeding from the kidney, sometimes other issues, and then that can manifest with sickle cell disease. And then many individuals would get gallstones. Some of them are silent, some of them cause problems. Liver can have more and more problems as you get older. And sometimes even the mesentery can get in the act. And so people can get stomach aches, but then it gets amplified by the sickling vasocclusion. And so the blood flow in the gut, which is in the blood vessel wall, could get impaired by just sickling itself, or if you have constipation on top of sickling, then you have vasocclusion in the gut wall and you can have gut wall problems. So those are all difficulties in sickle cell. And so with all this, and with the main idea that the blood cells are a problem, red blood cell transfusion has been a big factor in treatment for complications of sickle cell disease. And so that's why having a title of this talk, like non-transfusion treatment, has any meaning at all. That basically part of my job usually is giving red cell transfusions, and I have to do that and figure out who gets a transfusion. So who gets transfusions? One large group is children with stroke or risk of stroke in sickle cell disease. This very large study called the STOP study randomized children who were at high risk for stroke, found by this transcranial Doppler ultrasound screening test that we won't get into right now. But they were found to be at high risk of stroke, and then some got no transfusion and some got transfusions monthly. And the ones without transfusions, shown in this Kaplan-Meier curve, went from, at the start of this project, they were 100% stroke-free, but as we followed them along, within a year, many of them developed stroke, and so they were no longer stroke-free. And so more than 40% developed stroke if you just watched and did nothing in this study, this stroke study. This is in 1998. But those who got put on a transfusion program stayed pretty close to 100% stroke-free during this whole period of time compared to the ones who are suffering stroke. So with this project, with the data rolling out, the study was halted early because it was felt to be unethical to continue having children still be at risk for stroke with no treatment, and everybody got offered the transfusion program so that they could remain free of strokes. And this set the stage for a large number of screenings to see who is at high risk of stroke, and the ones who are found to be at high risk for stroke that were in the category shown in this graph would be offered transfusion on a monthly basis. And so many, many children with sickle cell got put on transfusions for this reason. And again, this is from about 1998, so more than 20 years ago. But as we kept on going, both from that activity as well as others, there are many downsides of transfusions that have appeared in the individuals with sickle cell. Besides all the ones that everybody else gets, with trouble accessing blood, with maybe iron overload, with the possibility of transfusion reaction, there's also a special sensitivity in sickle cell for getting immune sensitization to the donor antigens, that the surface of the blood cells in the donor is a little bit different than the surface in the individual with sickle cell, and the host makes a reaction against that donor blood. And that this occurs much more frequently in sickle cell than in almost any other disease condition, leading to basically an immune reaction and trouble cross-matching that person with a suitable donor. So many blood banks have difficulty finding a good cross-match for certain people who have many antibodies, and frequently these are individuals with sickle cell. So these have led to national guidelines in the US and internationally that transfusions need to be very judiciously chosen in sickle cell disease, that you don't just say, oh, you have a blood disorder, let's give you blood transfusion whenever possible because that will fix you. Instead, it's more like, let's choose the specific situations where a transfusion really ought to be given. And so one of these guidelines that came out very recently, basically during COVID, is from the American Society of Hematology, shown here at the bottom. And 3 excerpts from that guideline are when to transfuse, when transfusion would really be very necessary, would be recommended, is transfusing sickle cell patients with moderate or severe acute chest syndrome. So not mild acute chest syndrome, but if it gets to be moderate or severe, transfusion really is needed. The preoperative transfusions are recommended for long surgeries, something more than an hour, major surgeries. And then for some pregnancies in women with sickle cell disease, preventive transfusions help keep the mother and the baby in better shape to prevent sometimes maternal death, sometimes fetal demise, that the transfusions can be really important, as well as the one that I showed you from the STOP study, the prevention of stroke. What these guidelines also talk about is how pain itself is not an indication for transfusion. And so now we have other ways to try to prevent or treat. And so I'm going to talk about some of these. They're introduced here in this overview. These are 4 medicines now that we have approved in the United States for sickle cell disease, to actually try to have a specifically tested and proven commercially available medicine. These are on-label medicines for sickle cell disease. And this is shown as an infographic, but I'm going to go through in a little bit more detail. The first one that got approved was Hydroxyurea, and that was in about 1998, approved in 1998 in the US. And it got approved for children sometime after that, but it is now approved for children. It can make sickle cell disease milder in both adults and children, reducing pain episodes frequency by about half, reducing hospitalizations by about half, raising the hemoglobin level, less priapism pain, that's the sickling in the penis, that is a very difficult problem to manage other than try to prevent it. Increasing lifespan, there's more data rolling out indicating that. It's not super rigorous, but it's quite good by now in terms of numbers. There are fewer absences from school or work. Maintaining IQs is associated with hydroxyurea now. Again, the data are medium rigorous, but it's looking better and better all the time. And then the very, very nice thing is that hydroxyurea is an old medicine that is really not on patent anymore. So the expense is relatively low, and it can be affordable, relatively affordable in Africa, in Asia, and has been implemented on a large scale. There's even production in Nigeria of hydroxyurea. There's production in India of hydroxyurea. So you don't have to import this. It is available right there, where some of the people with sickle cell would need to get it. So you don't have to buy the hydroxyurea from like France to bring into Congo or something. You could get it from either Nigeria or someplace nearby. Hydroxyurea is starting to be tested as a head-to-head comparison against transfusion programs. Remember, I talked to you about stroke prevention. This, I'm not going to go into the details of it, but just a big picture is that for certain selected cases of children with sickle cell disease and stroke prevention needs, they could be switched from transfusions to hydroxyurea as a way to do stroke prevention. And this summarizes the typical systematic review meta-analysis approach that if you look at multiple clinical trials and you pool the results together, that overall the equivalence of hydroxyurea and transfusions is shown in this last little diamond-shaped thing that is showing equivalence. But the key thing is that in picking out who is suitable for this, you do have to exclude children who have certain high-risk features where really transfusions are still beneficial. And that exclusion of certain subgroups is the reason for these big spreads that certain studies showed hydroxyurea was same as sickle cell, as transfusions. So the closer they are to this dotted line, which is the ratio 1 would be that the protection level is the same between hydroxyurea and transfusions. So if a study crossed this dotted line, that means that 1 equivalence was part of the possible thing. And most of these studies did cross that dotted line, but there was one study that didn't, and one study kind of touched the dotted line. And that's where the inclusion of certain children who are high risk were found to be an issue. And for those children, still transfusions are better than hydroxyurea. But then we start to make more progress. Remember, that was 1998, both the transfusion stop study and the hydroxyurea approval. And it took another almost 20 years, but 2017, a new medicine was approved in the United States for sickle cell disease by FDA. And it's chemical name glutamine. So it's just an amino acid, one of the parts of the protein that we eat every day. And the brand name Endari is shown here. It's pharmacologically purified glutamine. I think they started with sugar cane and they went through chemical processes to break it down. But what the Endari does, that glutamine does, is it helps to alleviate oxidant stress. Remember, we talked about the hemolysis and how the hemoglobin being free in the system gives you a lot of oxidant damage and oxidant problems. So glutamine helps the body to fight that oxidant stress, and in the clinical trials, reduces pain frequency, reduces acute chest syndrome. And it's basically a food supplement. The next approval came just before COVID hit in the end of 2019. The chemical name voxelotor, the brand name Oxbrita. This is a chemical that binds covalently to the hemoglobin molecule and blocks sickling, blocks the sickle polymerization, because it keeps that hemoglobin in the oxy conformation, which doesn't polymerize. Very cool idea. And so this binds to the hemoglobin to do that and reduces hemolysis, keeps the red blood cells from having the polymer formation, the long curved shapes, keeps them from breaking up. and so it can raise hemoglobin by about 1 gram by doing this treatment. It is a preventive treatment. Crizanlizumab is the next one that got approved, and that was just like a month later, again, end of 2019. Crizanlizumab is the chemical name, Adakveo is the brand name. This is a monoclonal antibody that blocks adhesion. Remember, we talked about the stickiness, the cell-cell adhesion with the visual image of like sticky tape. This coats the blood cells to make these surfaces more smooth again, and blocking the stickiness helps the blood flow. And this, in clinical trials, was found to reduce pain frequency by about 1/3 or 1/4. Given as a preventive treatment also, not during acute pain. And so overall, you have now these 4 different kinds of treatments shown here in this infographic that was made by a medical student from my area, from my school over this past summer, to try to show some of the ideas about it. And we're going to walk through a little bit, because now you have 4. How do you choose which one to give? How do you choose which one to ask for insurance to cover? How do you choose which thing to give first? So one way to think about it is to start at the ages of eligibility. So each of these was approved with an age criterion in mind, that hydroxyurea is approved for basically 9 months or older. So even babies can get hydroxyurea, and there's evidence base for that choice. The glutamine is approved for 5 years and up. The voxelotor is approved for 12 years and up, and the crizanlizumab for 16 years and up. So I'm in pediatrics, and some of my patients, I can just tell them, well, right now you are 7 years old. And so mom, this child is eligible possibly for the hydroxyurea or for the glutamine, but the other ones, you're actually not old enough to be qualified for it yet. So let's try one of these 2. Another way to select might be the principal indication. So in the row below the names of the medicines is shown the principal indication for use of this medicine. So that for 3 of them, the hydroxyurea, for the glutamine, for the crizanlizumab, pain is the main indication. Frequent pain would be the indication for trying this medicine and trying to do its result that came from the controlled clinical trials that decreases pain. One of these medicines, voxelotor, the indication actually is to increase hemoglobin level, to manage that hemolysis and improve the anemia. It can probably help with pain, but that's not really the main indication. So you could choose some of these. You could also choose based on how they're given. So here are the 2 oral agents that reduce pain and acute chest syndrome. So if that's what my patient is having, if George is having frequent pain, frequent acute chest, he's in and out of the hospital a lot, maybe I need to talk to him more about hydroxyurea or glutamine, or maybe both, and that these would be ways to keep him from being hospitalized so much with season after season getting acute chest syndrome and having pain. And it's oral, so George can take this at home. If I have another person, maybe Liz, who has big, intense hemolysis and really intensely jaundiced eyes as a manifestation of that. Remember, more hemolysis, more breakage to get hemoglobin release also leads to more bilirubin formation. So the bright red, yellow jaundice type of color shown in my diagram. With the voxelotor, there are patients whose jaundice basically went away, no longer visible on the street as having jaundice. And so this may not help their pain that much, but it could help with the hemolysis. Increasing their hemoglobin can give a little bit more energy and endurance, but also that outward manifestation of the jaundice could be reduced. Again, voxelotor is an oral medicine that binds to the hemoglobin and reduces hemolysis. And then for some patients, I know that you're not good at taking medicines. You're not good at remembering to take medicines at home because you just keep on failing to have a habit of taking something. Your life is a little bit random. And that could be me too. My life is a little bit hectic. And so if I try to make a habit of taking a medicine every day, I would get it maybe like 70% or 60% of the time. And my wife is still working on that. But if I had a medicine that's given IV once a month, there's like no way I can miss that, or everybody knows that I've missed my appointment completely. And so one of these medicines is given IV, crizanlizumab, so you'd have pretty much enforced compliance. This is the one that blocks some of the stickiness. It's a monoclonal antibody that coat the P-selectin interaction and block the cell-cell adhesion. And this would have the benefit of trying to decrease pain in sickle cell. And then finally, you have the pragmatic choice reason of cost and ability to pay. I didn't specifically say, but you can imagine that new medicines, they're on patent, that took millions and millions of dollars to develop, are priced kind of expensive. They're actually priced at the way of, well, this will save you from having 3 hospitalizations a year. Let's price it pretty much at the similar cost as 3 hospitalizations a year, or maybe we'll price it at 2 hospitalizations a year. And so that would be the benefit in terms of economics. But that means maybe $1,000 a month treatment plan. So regulatory approval has occurred, but insurance may not want to cover it. There are other medicines that are still in the pipeline that are in testing that we're not going to talk about yet, but there are medicines that are approved in the United States, but not approved in Europe, or not approved in certain other countries in the Middle East, where public advocacy might help with making this available and persuading the funder of the medicines to be able to pay for this for the benefit of the people with sickle cell disease, and to give the regulatory agencies advocacy push for thumbs up. Now, I'm going to touch very briefly on this because this is shared between sickle cell and many other conditions, that there are things called oxygen carriers, artificial oxygen carriers, that can provide a bridge during an acute anemia. So these can be useful in sickle cell disease. The perfluorocarbon-based ones, the hemoglobin-based ones, some of them are also carboxyhemoglobin with a carbon monoxide bound in there. And they can be a bridge through a temporary short period, such as a viral suppression of the blood cell production that lasts for 10 days called aplastic crisis. But it's not a long-term solution, because this is a disease where you have a chronic anemia. And these oxygen carriers generally have a pretty short half-life, hours, maybe a day. And so to give it for lifelong has never been done, and is probably not going to be proposed. It would be way too much trouble, probably expose you to many, many more problems. So as a temporary bridge, they can be done. And there are many individuals who are Jehovah's Witnesses who participate in clinical trials of these in a sickle cell acute crisis, but they're not being used for long-term use, not even proposed for that. There is another treatment that I want to mention for those who are in clinical care, that there's a occasional rare event in sickle cell disease called bystander hemolytic crisis, where not just the donor red cells are getting destroyed by the immune system, but your own red blood cells are starting to get destroyed by the immune system too. The antibodies are shown here with these little Y-shaped guys that would bind to the surface of the red cell, erroneously attacking this red cell as a foreign invader. And then complement gets bound to that, shown with this little stack of blue things. And the complement has the ability, once it's bound to the surface, to blow a hole in the surface of the red cell and basically try to destroy it. Well, there is this new medicine, new meaning maybe 10 years ago now, called eculizumab, that is basically developed for another rare disease condition that involves ongoing complement binding and damage. But it was found in sickle cell disease to really help when somebody with sickle cell develops this bystander hemolytic crisis, that there's this period where the person with sickle cell has immune destruction and complement is the problem. How bigger problem was this. In sickle cell disease, there was no treatment for this, and people would just hope and pray that the person got through it without losing all their red blood cells. With the eculizumab, however, it is magic. It just unbelievably will shut down the complement fixation damage. And so you still might have some complement there, but it doesn't get that last step of blowing a hole in the red cell, and you don't have the hemolysis anymore. It is highly expensive medicine. It's like $1,000 a day, but it is the difference between death or days and days in intensive care unit versus you get treatment with this and you can basically walk away. So if anybody ever encounters bystander hemolytic crisis in sickle cell disease, you don't have to reach for these hemoglobin carriers. You should reach for eculizumab. In my hospital, if I want to use eculizumab, I have to get the approval of the hospital president. It's that expensive. But when we can justify it, it truly saves both money and suffering, and is an amazing new treatment. Eculizumab, make sure you know about that. There's also non-transfusion ways of trying to boost hemoglobin with EPO, with erythropoiesis stimulating agents such as erythropoietin, darbepoetin. And these have been used in individuals with sickle cell who get burnout of their own EPO production due to renal failure, or sometimes we need to boost somebody temporarily to get them through a surgical procedure. And so I've used this sometimes for Jehovah's Witness children, Jehovah's Witness from families with, yeah, I think you know what I mean, to get through surgical procedures with a temporary boost in their hemoglobin, as well as giving hydroxyurea or other things. Because if I only boost the hemoglobin without changing the properties, then all I have is more sickle red blood cells. And there's a problem if you just boost hematocrit in sickle cell disease, where hyperviscosity is a problem. So for those who are math inclined, this is a graph of oxygen delivery shown on the y-axis versus hemoglobin level in the x-axis. And for normal individuals, there's a curve that looks like this, that if you push hematocrit hemoglobin higher and higher, you get more and more oxygen delivery up to a point of about hemoglobin 15. After that, if you get more and more hemoglobin loaded into the person using EPO or something, you actually lose out on oxygen delivery. You can see the curve starts to fall. So as you get higher hemoglobins, you don't necessarily get more oxygen delivery, you get less. Why do you get less? Because the blood starts to get really thick and sludgy, more like molasses, more like tar, instead of like a liquid that flows. And so with normal blood, this curve has this peak around hemoglobin 15. But for sickle cell anemia, this curve is shifted, so the peak is instead at more like 10. So if you push somebody with hemoglobin SS, with sickle red blood cells, to hemoglobins higher than about 10 or 11, you actually lose out on oxygen delivery. If you do that, then you'll probably have somebody with more pain, more organ damage, with a higher hemoglobin, but it's not so good for them. But if you can do that with having hydroxyurea in place or having glutamine in place, other things to modify the red blood cells so they're not so abnormal, they don't sludge as much, and this curve is shifted more toward normal types of viscosity. So just more hemoglobin, more sickle red cells is not necessarily a good thing unless they're also modified to be healthier sickle red blood cells. And then the last concept I'm going to give here is that there's other non-transfusion therapies besides specifically on the blood. We mentioned earlier that sickle cell attacks so many different organ systems. Well, correspondingly, there are actually treatments to go with different of these organ systems. And the leading ones of these that I really don't want individuals with sickle cell to miss out on, the leading things for treatment are antibiotics and vaccinations. So early on in the course of history, it was found that individuals with sickle cell have a greater susceptibility to infections because of the functional spleen problems, the spleen not working. But preventive antibiotics and vaccinations were found to basically be able to make up for that. And so where it used to be that if you just had sickle cell disease and followed what happened to the individual with no particular treatment, 50% or 90% of the children with sickle cell would die before they got to even age 5. And so in places where there are no antibiotics or vaccinations available, because it's a poor country or because people hadn't heard of it, or you have delivery problems because of a disaster, natural disaster, economic disaster. If there's children with sickle cell disease who aren't getting antibiotics or vaccines, the rate of death before age 5 is somewhere in this neighborhood of 50%, 90%. They're dying of infections like pneumococcal bacteria, shown here with this little snowman-shaped Diplococcus bacteria. They could also be dying from malaria transmitted by mosquitoes. But with antibiotics and vaccinations, these children with sickle cell can survive to adulthood. And that's basically how we have newborn screening to detect who is a child with sickle cell, and why we try to provide antibiotics and vaccinations, including pneumococcal vaccinations, Haemophilus influenza, antibiotics to prevent malaria if you can. If you can get malaria vaccines, which are rolling out now, those are helpful too. And then other treatments would include fluids and analgesics. Having enough fluids helps to improve some of that. Where'd my blood vessel go? The stretchy blood vessel can be opened wider because of being well hydrated, whereas if you get dehydrated, it starts to collapse down. It's harder for blood to flow. Analgesics, pain treatments, goes without saying. If you have severe pain, you want to have some kind of pain treatment. Respiratory treatments so that people can get through acute chest syndrome, but also so they breathe well at times and not have oxygen delivery problems. I would encourage sickle cell patients to take up band instruments, take up, clarinet or trombone, or maybe even tuba. Take some big, deep breaths and keep those lungs working well. We have other tools in the hospital to encourage deep breathing. And for some, there's one group in West Africa where the obstetrics team has trained pregnant women with sickle cell disease to have a little balloon to blow up, and to take deep enough breath to blow up a rubber balloon or a rubber glove. Helps their lungs to fill more, less deoxygenation, less sickling. Physical therapists can help, behavioral health can help. Nutrition is still an area of active study, and we need more rigorous studies there. Accommodations at school and work can help keep somebody with sickle cell out of trouble. So I have some patients with sickle cell who are going to school in Chicago. It's very cold, part of the winter. So instead of having to walk 17 blocks to get to school, I try to get them to sign up for the school bus to be at least not be exposed to cold so much, because that cold vasoconstriction can trigger pain. Similarly, at work, there's some patients who maybe they're working as a cashier, and in the grocery stores in Chicago, many of the cashiers are basically right near the exit of the store. And so you're indoors, but every time somebody goes out the door, the cold wind blows right in and freezes all the cashiers. All the cashiers are wearing heavy winter coats and trying to keep gloves on their fingers while they're trying to work the cash register. Well, one way would be to not be at that station. Another way would be that there's certain other stores where the cash register is inside the store further, and you have a good 100 feet or maybe even 100 yards between where the cash register is and that door that opens out to the Chicago winter. Complementary and alternative medicine, social support are all important and things that we can do. Sickle cell centers are conducting clinical research that have led to those agents that I talked about. And I kind of blew through it quickly, but for like the EPO for sickle cell disease, there's a study that's just now getting started at University of Pittsburgh with Dr. Lewis Hsu, XU is her last name. And she's looking for international collaboration for study of how to bring more EPO to individuals with sickle cell. Shown here is that during a clinical research study, here's the young man who signed up for the study and his father. And around him is the clinical research team with study nurse from the Sickle Cell Center, a study nurse from the Clinical Research Center, with a doctor. At that time, I had more hair. And then surrounding all of these is also regulatory agencies watching to see how things go, monitoring for safety, making sure that we don't anything that's like a cowboy, following the rules and following safety regulations. And so you have the institutional regulations, the studies data safety monitoring board, you have the Food and Drug Administration, and also community groups, community-based groups like Sickle Cell Disease Association America, looking out for the patient. Everybody here has got the patient's interest in mind. And if people are interested in more clinical trials, there is this thing called clinicaltrials.gov, but there's a brand new one that really came out like 2 weeks ago from Sickle Cell Disease Association of America called Clinical Trial Finder that has a particular aggregation of clinical research studies for people with sickle cell disease. So if you want to find out more, I don't make any money from this. It's sicklecelldisease.net and then SCDAA Clinical Trial Finder. You can go there to look for this. For those who are clinicians, the ASH Pocket Guide is an app that you can have on your very own cell phone that has some of those guidelines that I talked to you about shown in a very easily accessible version of bullet points, where the whole guideline might be 85 or 100 pages. The app here puts it into like 7 bullet points, much more manageable when you're taking care of patients. And then you can feel free to look at the whole guideline so you understand what is going on. So in summary, what we tried to talk about is how this is the sickle cell disease is an inherited anemia that does affect people from all over the world, that specialist care is needed for optimal care because this is a multi-system problem that includes everything that the blood system touches, including infections with bacteria, infections with malaria, organs like kidneys, like lungs can all be affected. And so for optimal care, in a non-transfusion way, that includes also probably seeing other specialists or having somebody who can take care of your other organs. It does not mean sitting at home, never going to the doctor. Blood transfusions were the mainstay of treatment in sickle cell disease, but they are now reserved for certain high-risk conditions and usually for relatively short treatments. There are only some people who get long-term blood transfusions, usually that's involving stroke prevention. And there are exciting new progress and developments in non-transfusion preventive options for medicines that are approved and probably more on the way that can reduce the risks of getting into the acute problems of sickle cell disease. And so individuals with sickle cell should avail themselves of these. People who treat, doctors and nurses who treat sickle cell should know about these and try to lobby for their availability.